Hello, good morning, everyone. Thanks for joining. We'll just give everybody a few minutes so that maybe couple minutes so that they can join in, and then we'll get started here. So just bear with us. Thank you. All right. So again, I want to welcome everyone to this workshop. So this is, we wanted to talk about patient engagement and how that has changed in this new normal that we live in. It's been a rough ride for this country in general, and specifically for healthcare. And there have been some interesting changes that we've observed in how patients and providers communicate. Some of it has been organic, but a lot of it has been inorganic, and just given the circumstances, we've seen a lot of changes that we wanted to talk about, and specifically, what does that mean for risk-bearing providers, and how they can leverage some opportunities in these times. So before I get to further, I wanted to introduce the panel here. So I'll start and then I'll hand it over to my colleagues. So I'm Rakshay Jain. I'm a senior director within product at Innovaccer. As a matter of background, I've spent more than 10 years in healthcare management across various healthcare consulting firms, including Booz and Company, ZS Associates, and most recently Navigant Consulting. And my role here is to oversee product development for the provider vertical. With that, I'm going to hand it over to Dr. Paul Grundy to introduce himself as well.
Great to be with you today in this most fascinating of times. I'm Dr. Paul Grundy. I'm the Chief Transformation Officer at Innovaccer. Prior to my role at Innovaccer, I was the Chief Medical Officer for many years at IBM, and before that with the U.S. Department of State. I'm also the founding president of the organization known as the Primary Care Collaborative that really drove the concept of the medical home, robust-based primary care and population health. I'm the author of a couple of books on provider-led population health, so it's a pleasure to join you today.
Thanks, Dr. Grundy. Evan, do you want to introduce yourself?
Hi, I'm Evan Grossman. I am the Chief Product Officer at Innovaccer. I've spent 10 years in product development for healthcare technology, and 20 years before that in other product development. Spent about 10 years at Athena Health on the electronic health record and integration side, and been at Innovaccer for a year, really focusing on population health and how to drive improved outcomes for our provider clients.
Perfect. Thank you for introducing yourself. So with that, I want to get started. So just to set the agenda for today, we have some content that we've developed around our analysis of how patient engagement has changed in this pandemic, and what are some of the things that we can do strategically to help counter some of those. Again, there have been some changes from a regulation standpoint, which we will discuss, and then ended up with some ways in which we can address that, and also think through some solutions specifically from Innovaccer. So with that, I want to jump in and just set the stage here. So we've seen, like I mentioned at the start, a tremendous amount of change in how patients and providers communicate. So some statistics that would be of interest. We've seen a significant drop in preventative and elective procedures. So what that means is that a lot of mechanisms that our provider colleagues use to measure and manage outcomes have disappeared. So for example, and we'll see a few slides around data that support these hypotheses, in which the number of screenings have gone down tremendously. Additionally, the number of visits have gone down by almost 60%. And while some of that, while we've seen an uptick in the telehealth visits, but those haven't really made up for the overall decline. So we'll see some numbers around that. And then finally, there are some long-term implications, given that there has been a dip in preventative care or preventative visits in the short term. So that has a potential of increasing the costs to the healthcare system overall in the longer term. So those are some of the ideas, but let me just jump in and show some data that we have collected from various online sources. So as I mentioned, the ambulatory visits have declined by almost 60%. They've been on the there's been an upswing and a rebound of sorts starting early April, as you can see, but still it's 33% lower than pre-pandemic levels. So while this will start to inch up, we believe, but still, you know, it has really changed the way, as I mentioned, in which we think about interactions. And at the same time, the preventative screenings have gone down. What you see on the screen here are breast cancer, colon cancer, and cervical cancer screenings. So they've seen a huge drop in the short term. The line in the middle is actually the mean screening volume from 2017 to 2020. So Jan of 2020, so pre-pandemic basically, and you see that there's a huge delta, anywhere between 80 to 90%. So that's a huge drop. And you know what that means is, especially from a value-based care perspective, that we've not been able to do the necessary checkups to close care gaps. We've not been able to address some of the issues so that we prevent problems down the road. On the flip side, and again, there's been a lot of regulatory movement as well, which we'll come to in a bit. The number of telehealth visits as a percentage of the total visits have increased. However, at the same time, you know, although we have seen an uptake in telehealth visits, but we've also seen some reimbursement changes around that, but still the overall number of visits has reduced. So this is building up to a place in which we need to start thinking about, is there a different way in which we want to interact with our patients, and what does it mean in the next 3 to 6 months on what are some strategic imperatives we want to focus on in terms of trying to bring patients back effectively, and also ensure that, you know, we're meeting some of our value-based care goals. I'm going to pause here and actually ask Dr. Paul Grundy to see if he has any thoughts on what are some of the long-term implications of these trends that we're seeing, in which we see less in-person visits, more telehealth visits, and what does that mean specifically for risk-based providers? Dr. Grundy?
I think you're muted, Dr. Grundy.
You're absolutely right. I tend to turn my mute on when I'm not talking. I apologize. So I just got off a call with a board call for the ACGME that oversees all the residency training. And the consensus of the leadership there, mostly from systems and medical schools, is that much of the change that we're seeing was change that was already underway. This has just sped it up, right? The consensus there was also never waste a crisis. Many of the changes that we're seeing, we needed to see, which I thought was pretty interesting and positive. And in talking to the CEO of North Shore, the system in the country that happens to have had the most number of cases of COVID, and they've lost $1.2 billion, they were actually pretty bullish about the future in terms of really driving community-based care, really integrating social determinants of health, really looking at the factors that mattered that needed to change. So interestingly enough, the folks that I've recently interacted with are pretty positive about the changes we're seeing and thought they were already beginning to happen.
Thanks, Dr. Grundy. Evan, do you want to add some thoughts there?
Now I was the one on mute. Let me do the counterpoint, because I love that optimistic view, right? And I am hopeful. I think what we've seen, what I've talked to many colleagues saying is, for years, people have been urging practices not to bring patients in when they don't really need to come in for simple things and to do things via the telephone. And COVID has forced the issue. So that's the positive side. The negative side is, some of the slides Rakshay was showing earlier. Like, will we ever get, is it a 3-month gap in colon cancer screening now? So everyone is sort of 3 months delayed from where they were? Or does it actually mean that some people, it may be another year, another 2 years, depending what would prompt them to get that screening to begin with? So I think, we're going to need to be very careful as things open back up to understand what are the high priority gaps and make sure they get filled. Whether in person, over telephone, send a fit kit in the mail, right? I mean, there's a number of ways that these gaps can be addressed, but I'm a little concerned that some of the normal treatment that might prevent more acute episodes may not be happening. So that's what I think we have to pay attention to.
And I would completely agree with that. I happen to be a healthcare ambassador for the nation of Denmark, and I've been working with them for almost 2 decades. And they've moved over the past couple of decades to about 87% of all care being done virtually. And interestingly enough, Evan, to your comment, is that within a couple of years, we actually did not see a decrease in face-to-face visits. There's that human need for touch. And certainly there's that human need for touch when you haven't screened, when you haven't screened your patients for breast cancer, et cetera, right? Maybe with colon screening, we can do something else now, but yeah. I mean, I completely agree.
I mean, I don't know where you are in Cologuard, the exact sciences kit, but I mean, I think that there are a number of ways to, right? And I think the interesting question is, so much of the standard workflow and practices is based on get the patient in and then do some follow-up screenings or schedule them for, right? And I think we need to kind of flip that and say, okay, what does the patient really need? And if we're concerned about, we're not worried about an annual wellness visit for an otherwise healthy 60-year-old male, but they're up for a colonoscopy, let's reach out, let's send them a fit, let's figure out what to do. Likewise, there may be plenty of parts of a healthy visit that can be done virtually, and then you could arrange a drive-by phlebotomist meeting, essentially, where you're then if you want to check cholesterol levels or some other standard things where you're doing that. So I think this is really going to challenge workflows, but those practices that are flexible and can figure out how to decouple, right? Because the whole kitchen sink was thrown into the annual visit for a large number of patients. And if you figure out how to decouple some of those things, you might actually be able to provide better health at less cost.
And it's a matter of your perspective. I mean, the Cologuard, the DNA testing for colon cancer is clearly going to have an impact on those guys that get a lot of their income from scoping, right? So it's going to not be without pain, I can guarantee you.
Yep. And I think, and these are great points. So thank you, Dr. Grundy and Evan. I think one of the things that I'm hearing is that it's very important to understand what the preferences of the patient are, and actually even before that, understand like what type of approach will make sense for which type of patient. So let's say if there is a low risk patient, for them maybe a DIY kit or a Cologuard or a fit test might work for a colon cancer screening. But then if there's a higher risk patient, maybe we do need to bring them in at some point. And how do we make that happen as well?
Right. So the thing I would say, just to sort of get us back to not that we've been off at the topic of the webinar, under either fee for service or fee for value, one of the most critical success factors for a practice is the ability to bring patients in when they need the patients in and keep patients out when they don't need the patients in. Exactly. And I think that This is highlighting that even further. And those practices that can engage with their patients, maybe to just arrange a screening test, as I said, a drive-by phlebotomist visit, versus come into the office and have a full physical exam. The more ability you have to engage the patients and get them to do the limited task that you need, the more successful, both financially and health-wise, I think the practices will be. Under either, and this is not just a fee-for-value issue, this is fee-for-service as well.
And the more convenient you make it for the patient, the more likely you are going to have them do it. You're completely right.
Triple aim, we are absolutely aligned.
Absolutely. Cool. Well, I think those are great thoughts. So just let me keep pressing on here. So the next section, we wanted to talk about what does that mean for risk-bearing providers, and just want to start with highlighting some of the changes that have made. So CMS again has been very proactive during this crisis, and we really thank them for that. They've a few things that I wanted to point out. So they've pushed out quality reporting timelines for especially MSSP ACOs. They've increased the telehealth reimbursement, and they've brought them closer to what they paid for office and outpatient care in general. So that's definitely an incentive for providers to try to make that switch from in-person to virtual. And then, very specifically, just as a lot of people in this workshop might have already realized, that there's been a move to higher risk models in MSSP as well. And one of the things that was happening was in basic track, you had to progress a risk level each year, and they've basically the ACOs in basic track for this year have a free pass, and then in 2021 they will advance 2 levels. So they don't need to advance to the higher level of risk in this year. So I think that those are definitely things that help in the short term. And there are some provisions even around ACOs who are taking downside risk to limit the downside risk around a PHE clause, because this is a public health emergency. And if there are ACOs who are taking downside risk, so their downside will be capped, just given what has happened. So there are solutions, just to kind of summarize, that have come from the regulatory bodies, but we strongly believe that this is not enough. And some of the things that Dr. Grundy and Evan were talking about previously, that we do need to understand, the patients have seen that there is a different way in which they can now interact with their healthcare providers, right? So as part of the healthcare community, we need to come together and understand, like, what is the new normal, and then double down on some patient engagement strategies, whether it's through outreach, whether it's through virtual channels, whether it's through a patient portal, whether it's through DIY kits, whether it's through a patient app. So we just need to figure out what is the right way to interact with which type of patient, depending on whether they're high risk, maybe they have a communication preference. So there is a need to double down and understand how our patients perceive healthcare providers, and what would they be preferences to interact. Specifically for value-based care, and again, this is based on a lot of experience that we've had helping activate patient engagement solutions for risk-bearing providers. So there are value levers that you can impact using patient engagement solutions. To give a few examples, we've got utilization management, in which you can manage transitions of care by sending outreach to patients to ensure that they go for their PCP follow-ups. Then you can also impact ED utilization by educating patients on appropriate site of care, so that they know, if they have a cough or cold, they need to go to an urgent care center, versus, if they have something more serious, they can go at an ED. Again, the goal being to manage utilization and manage cost for the population. Then coming to the quality management side, there is obviously value to getting as many annual wellness visits done to ensure that we're getting patients checked at the right point, and if there is any intervention required, we can do that in a timely way. And more importantly, just to understand what's the current risk level of the patient. Are there any clinical or coding gaps that we want to monitor? So they can be campaigns that you can initiate, reminders that you can send, and we can also be creative about it. They could be videos from their PCP. We can think of psychographic profiling, in which if you're requesting them to do something, some users might respond to different messages. Let's say there is somebody who's more introverted versus extroverted, so different type of messaging might work for either personality. So we can be creative about it to ensure that there's compliance there as well. And then finally, talking about chronic diseases, there could be disease-specific care plans that you can engage the patients on. And then, let's say they have diabetes and there's a certain set of tasks that you need to do. You can create care plans. You can push that to a patient application that they have either on their phone or on a desktop, and just ask them to go down a checklist, and a care manager and a patient can collaborate to ensure they're taking care of themselves appropriately. And I'm sorry, I should have probably mentioned this at the start. There is a chat box at the right, and please feel free to put any questions. I have an eye on that as well, and I can then try to ask our panelists to try to answer those. So again, we want this to be interactive, so please don't hesitate to pose your questions there. With that said, I want to again turn it back to Dr. Grundy and Evan to see if they have any thoughts on what are some of the impacts, or what are some of the considerations that risk-bearing providers should take when it comes to patient engagement post-pandemic.
We got the mute problem again.
I always say, thank goodness we've left the age of information and we've moved into the age of intelligence. With AI-supported tools, you can really hone in on how you message that patient and engage them. I mean, a woman with 3 kids who works, the data shows that they're most likely to respond to a text from their personal physician or a short video reminding them of what they need to do after 8 on Tuesday. It's the way Amazon markets. It's the way you're marketed to now. But that's possible because those tools really can look at patterns in ways that we humans can't put a million different things together. But the ability to engage patients now and get them to respond to what you need them to do is much stronger than it used to be with these modern tools. So it's actually a pretty exciting time.
Absolutely, and I think that's well said. And we'll see some of that in the coming pages on how we can use technology to enable most of those workflows. Evan, do you want to add any thoughts here?
Yeah, I mean, I would just again say, in addition to sort of right message to the right patient at the right time, right, which AI can really help with, I think it's also important for practices to really think through how to segment your patient populations around workflows. Again, back to the annual wellness visit. Who can you do an annual wellness visit with over the phone? What's the right way to do some of the assessments, whether it's a PHQ-9 or a functional assessment in advance of the visit, which is a good idea anyway to reduce physician time and have an MA or someone else take the patient through the assessment, but really start breaking down the components of the workflow and figuring out which can be done virtually. Because what we don't know what the new normal looks like. I think for many patients, there's going to be a long time before they are comfortable just walking into a physician's practice. And so the more that the practices can show not just the steps and care they're taking to keep their practices safe and their patients in those practices safe, but the steps they're doing to avoid unnecessary contact, right? And through what I've talked about in terms of breaking down the workflow, the more important it is. And I think being very explicit in some of the outreach, right? When we talk about psychographic profiling, there are some patients that are very nervous about face-to-face contact, or in-person contact, I should say. And let's find out how to identify them and propose other alternatives that they'd be comfortable with, so that we're treating each patient in a way that they're comfortable being treated.
And I like to think simplistically that this is really migrating into a team sport. And the two things that the physician should do with their time, really only two things: difficult diagnostic dilemmas, because that's what we spend years learning how to do, and relationships of trust. Everything else is probably better done by somebody else. Medication management, probably better by a clinical pharmacist. Patient education, maybe by a nurse educator, but to the point that Evan made, I mean, this is really a good time to focus in on getting the maximum value out of what a physician should be doing, which is difficult diagnostic dilemmas and relationship building.
Yeah, I think it's a 2x2 grid, right? That I encourage practice to think about what a physician should be doing versus how the other folks in the practice work to their highest level of the license. And then in each of those grids, what needs to be done face-to-face and what could be done virtually.
Exactly.
Because a lot of medication management can be done virtually, but a blood draw can't, right? Some physician relation, could you? I don't know. It's probably a good question on your, increasingly, I'd like to think practices are working around advanced directives and truly is that something that you want to start on virtually? Maybe not, but it's certainly something that doesn't have to be done face-to-face. And so really understanding what are those things that can be done face-to-face, what are the things that can be done virtually, and then as you decompose the workflow, coming up with that team sport approach could be very valuable.
Absolutely. Absolutely. And I think those are great thoughts. So thanks, Dr. Grundy and Evan. And that's a good segue into our first poll. Again, we wanted to understand from the attendees here, like what are some of your key challenges with patient engagement? And we've touched upon some of these, but just to reiterate, is it reassuring patients to come back for visits, that they're not comfortable, to Evan's point, if there's there's a certain preference of a patient to be viewed remotely, or is it lower gap closure, and the worry is that we might not meet our performance targets and quality scores by the end of the year? Or is it that we have virtual channels, but we're not able to engage our patients through those? Or maybe the fourth is that we haven't really strategically developed systems around engaging with patients, whether it be from a technology standpoint or a process standpoint. So we'd love to understand, again, these are multiple choice questions, so feel free to choose 2 or 3 or all the 4, or maybe just one, whatever is applicable, but would love to learn from the audience here. The poll is live now, so please, if you can, just in the next minute or so, log your responses so that we can have some results. I think while we're waiting, we can take some questions. Again, if there are any queries on the content that has been discussed till now, we'd love to again get those answered at this point. All right, so the results just came in. So 63% feel that reassuring patients to come in for due visits. So that's basically the top of the list. A close second is lower care gap closure. So those two seem to be the major concerns for this group. And then I think lack of engagement and lack of systems to engage with patients seem to be lower on the value chain here. But again, I think that makes a lot of sense, and that aligns with what we've been seeing with some of our clients. Again, it's really top of mind for ACOs to ensure that they can get those preventative screenings done, and we'll have some thoughts, and it's a good segue into the next section where we want to present some strategies that you can do to address both. So with that, let me just move ahead. So again, just outlining how do we manage in this new world, and how do we engage with our patients. So the first piece of it is, again, reassuring patients. Now, whether it is getting some assessments filled beforehand so that we optimize their time in the physician's office, or is it engaging with them through their app to do some of the work that was usually done in person, and we'll see elements of that in a bit. The second, which again also came up as one of the major concerns, is targeted outreach. So how can we identify the right registry of patients which need to be outreached to, and what are the right modes of communication to reach out to them? Is it text? Is it phone? Is it snail mail? Probably not, but again, we know some patients prefer that as well. And to get some of those care gaps closed. And then finally, how do we engage with our patients virtually? Let's say we have patients who are extremely uncomfortable coming in, and the only option is to engage with them through virtual channels. What are some strategies around that? So with that, let me just jump in. We want to talk about each of these in a little bit more detail. So again, wanted to open it up to Dr. Grundy and Evan to again share thoughts on what is it that healthcare providers can do to reassure patients that it's safe to visit their practices again.
So
and
go ahead, Evan, you're on first.
yeah, I was going to say that the first thing, right, is to not bring them into the practice if they're not needed, right? So not to be cute with the answer, but like, to the extent that patients understand you're only bringing them into the office when you absolutely need them, they'll feel a lot more comfortable and trusting that, okay, they were able to do this virtually, they're able to do that virtually, but they actually need my blood, and so I've got to go and have a draw done, or they need to do they need to do a screening that can't be done over the phone, right? So I think that's the first thing, is assuring them not just that we're sanitizing our facilities daily, but that we're only asking people to come in on items that are really important, and that we actually have already come up with really good ways of not having you come in, and here's the things we're going to do without you in the office, but here's when we're going to need to see you.
And I just had this conversation in my role as advisor for Denmark, and we're just opening up our practices there. Clearly signage that lets people know that they should be wearing a mask, that it's structured in a way where your appointment is scheduled at an interval of time where there are not going to be a lot of people in the office, and a reassurance that's happening. Lines on the floor demonstrating safe distance. I mean, really clearly demonstrating that you're following the kind of rules that will minimize infection, I think, is going to be important. But the other thing that is really important is the concern that the practices have of opening their office because they'll be infected, right? Which was a huge part of the conversation with the Danish community.
Absolutely, and I think there are in my opinion, there are a couple of ways to tackle it. One is through technology. The second is just revamping the processes that you have or you're used to follow. So, for example, if there is a patient who comes in, can we make them wait in the car while we manage versus them coming into the waiting room? Or can we, to my earlier point, can we use the patient app to do some of the pre-office visits? So I think it's a combination of both, and I think to Dr. Grundy's point, this is the new normal. The practices also need to demonstrate that they are taking all the precautions, and there are you see a wide spectrum even in the area that I live in, which there are physician offices who are or practices who are very strategic about that, and they proactively reach out to their patients, and they're sending them communications around these are the measures we are taking. It's perfectly comfortable to come in. And then even when you go in, you see that there are a lot of resources who are managing patient workflows. One of the practices have actually had an area that in their parking lot, which is now dedicated for any patients who are at risk for COVID, and the rest of the facility is dedicated to all the non-COVID patients, so that they completely segregate those two. And so I think those are the kind of things that we need to think about to ensure that patients are comfortable to come in. And again, to Evan's point, if there is a way in which we can prevent them coming in completely, that's probably the best, at least in the short term.
And I'd look at what restaurants, what retail, what other people are doing, right? If I would, ideally, if you depending what kiosk technology you're using for patient registration, or if you're still using clipboards, right? You could absolutely tell a patient, look, when you arrive in our parking lot, text this number, and we'll come out with a sanitized iPad for you to fill out your PHQ-9 assessment, right? If you don't want to do it online, we'll come out with the iPad to do that. And when you're done, we will then text you when it's time to come into the office, right? So you can actually do a lot of what's normally done at the front desk, depending on your technology. If you have Square or something, you can even collect the copay car side. And I think that's both safer for the staff and safer for the patient. So I'd really think about the current workflows. I assume most of the people on this call have had experience. I'm in the Boston area, Rakshay's in the Bay Area, so we're on opposite coast, but we have had lots of different experiences with how different organizations have adapted, whether it's the grocery stores with blue tape on the floor at 6-foot distances, or Best Buy that's just sort of showing up at your car with whatever you've purchased. There are a number of ways that people have adapted, and showing your patients that you are adapting as well in ways that keep them and keep your staff safe is only going to help that trust over the long term.
Absolutely. Again, great thoughts. Let me just keep moving here. So the second lever that we mentioned was targeted outreach. And we've actually done this successfully with a few clients, in which we've created dashboards in which they can track what are the patients, or actually, let me correct myself, what are the measures that have the most gap to what their target is. So let's say it's breast cancer screening, or it's colon cancer screening, or it's just their target of annual wellness visits. So we need to have that kind of data at our fingertips, to be able to track that what was the care gap closure last year or in the last 2 years, and how is the current year trending, and what are some of the biggest gaps there. And once you identify that cohort of patients, then it should be seamless to download that list of patients and then send them an outreach based on their preferred method of contact. And that's where some of the technology that we'll talk about in a bit comes in, and we can ensure that your you're reaching out to the patients with the right message in their language preference, and with all the relevant details. Let's say that you're reaching out for a breast cancer screening, or requesting them to schedule a breast cancer screening visit. Are we providing them the right next steps in which they need, either they need to call in to their physician's office to schedule that, or we're just enabling that last mile as well? So that becomes really important. Or there could be, as we've been talking about, there could be DIY screening or tests that could be sent in to them if they can't come in. So, but it all starts with identifying the right patient cohort, which have those gaps, and then figuring out, okay, what's the right way to reach out to them, to either bring them in or maybe make them do that screening at home itself, and then just record that. Let me just pause here and see if Dr. Grundy and Evan, love to hear your thoughts as well.
Nothing for me at this stage. I think it would be great for us to see how some of these tools could help us deliver this value.
Yeah, +1 from me.
Absolutely. All right. So let's then get right into it. So in the next phase, but before we go there, or maybe we can come back to this at the end and see if we've kind of hit upon the points that we wanted to. So let's just start with the patient app. So what I'm going to do now is I'm going to show you how using a patient app, one can take a COVID-19 assessment, locate a test center, and then schedule a virtual visit. And again, this is very relevant given the times we are in. So just allow me to change my screen here while I bring up the right. Okay. All right. All right, so this is a patient app, and apologize, I just had to move through a few screens, but this is the home page in which, as you can see, we have the COVID-19 screening assessment that a patient can see. We also have the option if they want to find the test centers nearby. If I scroll down, they also have an option to speak with their doctor if they want to. And then, if they are on an active care plan, let's say in this example, Joy Lawson had a total knee replacement, and their care managers want to engage with them and track progress, so they can do that through this app. We also have the ability to show the patient their health record. So if I click on this, you can see all the details on their allergies, their diagnoses, their vitals, any visits, family history. So that basically gives a lot of information to the patient at their fingertip. If I click on any one of these, we can see their vitals, and this could be recorded at any point of time, and we can show them either in a day, week, month, or year view. We can also connect through to third-party applications like Fitbit and Apple Health to ensure that we're also getting patient-reported data inside. But for the purposes of this demo, I also wanted to show how a patient can go through a COVID screening assessment. So once they click on the COVID-19 assessment, we have these fields that pop up. Most of this would be pre-populated because we have this information, so the patient would not have to fill anything, and then they go through a standard assessment. So in this case, the first question is around the race, so we enter that. Then it's about the are you an essential worker or not? In this case, the worker is an essential worker, so they click yes. On the next screen, we ask, has the patient been in close contact with anyone who is confirmed with COVID-19, this patient has. So that increases their probability of being diagnosed with COVID-19. But then there are a few other questions which now talk about symptoms. So do they have they had a fever? So in this case, the patient has not had a fever. Then then the question is around some of the symptoms that are associated with COVID-19, and again, CDC has updated some of those in the past few weeks. So we have that list here, but the patient in this question does not have any of these. And then finally, if there are any comorbidities, and this patient has none. So based on this assessment, there's an algorithm that runs at the back end and gives them an assessment. So this patient is not likely a suspect for COVID-19. But again, if they are still not sure about it, they have an option to go and find a test center to be 100% sure. Again, there, as we were talking earlier, there's a broad spectrum of patients. Some are easily convinced, some are not. So they can go in and find a test center. They can enter their address, in this case, 221 Baker Street, New York. And then they get a list of all the test centers nearby. We also integrate at the back end with the details around this test center. So we can provide key information around what's the phone number if you want to call in, what's their address, how far away from the patient is that center, and then is there an appointment required, do they collect samples and whatnot, and then there's a one click to either navigate or call. So we made it very easy for the patient to again do an assessment, figure out if they are at risk for COVID-19 or not, and then if needed, go to a test center. The other option is if you want to talk to a doctor right away, so we can enable that as well. So once you click on this, it prompts you for the top reasons why you would want to talk to a doctor. So that's basically COVID-19, just given the times, and then we've got cold, cough, flu, or back pain. There could be other reasons as well that you choose. But again, for the purposes of this demo, I'm going to select COVID-19. So the first prompt is what brings them here. So I just I fill in, I'm experiencing mild cough and sore throat. And then the second prompt is this for the person who's filling this out, or is it for a minor? So for the purposes of this demo, I'm going to select myself. And then we are prompted with a list of physicians that are available. And this list is pre-populated because these physicians are on our platform. So we have real-time visibility into their schedules. So for the purposes of this demo, I'm going to assume Dr. Noah Mellon, and I'm going to select him. And then what happens is that the patient is placed in a waiting queue. And again, we've worked on this workflow, and we've tried to understand some of the intricacies around. So if there is a step required before this in which they need to be routed through to an MA or the front office, we can enable that so that they can collect the details before they speak to the physician. Or some patients might request for a translator, or maybe the practice wants to have a coder on, so we can add multiple people to the call. But for the purposes of this demo, let's assume it's just between the patient and the physician. So you just click on it. The virtual visit will start automatically once the physician is available, and then once the visit is complete, it will just ask you for your experience, and then we can go back to the screen here. So that's the workflow, and this is again a quick description of the patient app. There are opportunities for the physician or the care manager and the patient to communicate one-on-one. We have a log of the call history here, and then we have the patient profile, which logs their insurance payment methods and health records. So with that, I want to switch back to the presentation and want to go to the next step of this demo. So this was the patient app that you viewed. And then what I want to show you is the outreach piece of it. How do you create a registry, and how do you select the right survey or campaign to send out to the patient, and how do you engage with the patient, and how does that information flow back into our system, and then how do you evaluate performance? So for that, I want to hand it over to my colleague Vani, and she's going to walk us through the workflow, again focusing more on the initial piece of it. I do want to reserve a few minutes at the end for any questions, but yeah, we will show you how we can create a registry and do an outreach to a certain set of patients. So over to you, Vani.
Yeah, thanks, Rakshay. So what I'm going to do is that I'll just give a glimpse of how you can send out a targeted campaign which is simpler to do and which is effective in terms of the engagement and in terms of the responses that you get from the patients. So on the screen, you can see that I am on the campaigns listing page. You can see all the campaigns that have been sent till now, who are the creators of those campaigns, and what is the status of the campaigns looking like. So for example, for this particular campaign, ER education, I can see that there's an open rate of 49%. So that gives you an overall glimpse of how your campaign is performing. What I'll do right now is I'll start a new campaign. You can see that there are two options available. There's a message campaign and a survey campaign both. So message campaign is like the transactional message that we get. It's more of sort of a reminder where there's some call to action for the patient, maybe a number of the facility on which the patient can call back. What I'm going to do right now is that I'll try to send a satisfaction survey for all the patients who have been discharged in the last 2 days. So you can see that I'm naming the survey as satisfaction survey. I'm also choosing text as the mode of communication. Once I do that, so it's how we have visualized outreach and our vision is that it's a simple, easy to use 3-step process. You find the target population just so that it's more effective and it's relatable. You also find the right message, whether it's the language support or the messaging, or if there's any personalized effect that you want to add. And then you review and sort of send the campaign with the right timings. So what I'll do is that I'll quickly form a new patient group registry, as we call it. I'll name it as discharge group. When I come here, I see that I have two options. I can either upload an Excel or a CSV file. So if you have your IT team or if you have the list of the patients from your providers already, you can upload that here. Or you can also pick some patients under some conditions. So all the data that we get, we sort of normalize that, and we also provide you with certain filters so that you don't have to do the manual work of uploading a file here. I'll choose this option so that when I come on the next screen, I see that there are 7 options available as filters. I've also chosen discharged patients in the last 2 days. So what you can do is you can also put in the care gaps condition, maybe if you want to target the breast cancer population patients, or maybe if you want to target the high risk population. So you can do all of those conditions here. I'll quickly put in the condition of the discharged patients in the last 2 days. And also the patients who belong to the Aetna plans. As I move forward, I see that there are 230 patients who are eligible under the conditions that I just applied. I move to the next step. I see that there's already a list of pre-built templates available on the system, some of which are already industry standards like PHQ2, PHQ9. I'll go ahead and I'll just take a quick preview of what the questions are looking like in the survey. So I see that there are 10 questions. It's a 2 minutes activity for the patient, and I can see the questions and the options that will be available for the patient. I choose this one. So now when I come here, I see that there's an introductory message attached as well. So for example, if I could draw parallel to this COVID scenario, you could add some remarks here that, hey, we are doing all the daily necessary sanitization or cleanliness that should happen in the practices. So it's sort of safe for you to come back to the office, or if you want to add any other notification around, maybe wear a mask or maybe take a water bottle with you, you can do all of that. I'll quickly add the language support. So we offer English, Spanish, and French as our default support options. But if you have any other language preference, we can add them too. Now I quickly move to the next step. I see that, okay, I have chosen all the preferred number of the senders. This is the group that I want to target. On the bottom, I can see that I can either send the campaign right now or I can schedule it for later. I also see that out of the 230 patients, there are 12 patients who have opted out of the conversation. So they would not be receiving these messages to comply with the HIPAA and TCPA compliance. I go ahead and I send the campaign. So now the campaign has been sent. Now I can see that there's an open rate or the fill rate, the engagement received is 86%. I go here and I see that 200 patients have completed the survey. And you can also get the drill down of all the responses that you have got from the patients. You can see that there are 7% patients who have not responded to your questions. So now you can download this list as well, so that if you want to take any follow-up actions, maybe you want to call them up on your own, you can do that too. And I will also quickly show how it looks like on the patient side. So it's the easy to use interface, like they get a message, there's a link to it. You take the consent of the patient, you start filling up the options. I say that I'm feeling pretty much fine, and I say that I have been taking all the medicines in time, so I do that and I send the survey. So quickly, I'll just show how the analytics is being tracked. So all the responses received by the patients are visible in a dashboard, where you can get an overall view of what the engagement rate is looking like, what's the overall rating, what's the engagement trend, and what are the facilities, how they have been performing, and then you can further drill down to see what is going wrong with those practices and if there's something that you can do to make the situation better there. So with that, Rakshay, I'll hand it over back to you.
Thanks, Vani, and appreciate the quick walkthrough. Again, if there is more interest, please don't hesitate to reach out to us. And with that, I want to take some questions. I know there have been some questions that have come in. So the first question is around what are people using for cognitive assessment when performing an annual wellness visit through audio only? So that's a great question. That's I think part of the challenge why we want to bring patients in for some of the reasons, or if there's an option to do some of that virtually. But again, I will ask Dr. Grundy to take that on and give us his clinical perspective on that one.
So one of the practices that I've been talking to, they have made arrangements with the local phlebotomer to sort of wait in the car for the patients until they wait until their appointment is called. So there's only one going in at a time, very sterile environment. So the blood tests are done in that way, and then they send some screening kits out to the home, including blood pressure and pulse oximeters and other things as well. But I think that only is going to last so long. I think that my experience with seeing what's happened over the years in Denmark is that it won't be very long before people are reassured enough and begin to go into their provider if you assure them with enough assurance that they're going to be safe.
Absolutely. All right, thanks, Dr. Grundy. One of the other questions that has come in is that are the COVID assessment questions that were shown from CDC or your own? I think the template that you saw was inspired from CDC, but in the actual application, we have CDC approved questions. And this application is available for download. So, anyone can download either on their iPhone or Android application. But we do follow the CDC approved assessment. And then again, if there's a need to customize the questionnaire, we are happy to do that based on the organization. The second question that is common is if the COVID assessment determines a high probability for COVID-19, does that information go anywhere? What if the patient doesn't do a test or consults a doctor? So the answer is yes. If it's a high risk patient, the information flows back to the PCP. And then, we usually have the information of the primary care physician at the back end. And then, it's up to the primary care physician to either take action, or if the patient wants to take action, they can also do that through the app. So those are a couple of questions on the demo. There's another question around the guidelines, and I would want to get thoughts of Dr. Grundy and Evan. I know we are almost at the top of the hour, but maybe we can sneak in this other question. So is there going to be guidelines on which patients and providers can follow on whether deciding when to do virtual visits and when to do in-person visits? Any thoughts there?
Evan, you want to go first?
Well, I guess that I'd follow the guidance in general, but I think we need the better science, which is as virtual as possible, as physical as necessary, right? So I think that would be the first thing I would take into account. I'll leave it to Dr. Grundy and the others to determine under what circumstances a visit absolutely has to be in person, and even then might not be advised.
I think you covered it pretty well, Evan, since we've reached the end of the hour. I'll turn it back to.
Yeah. All right. Yeah, I think just one quick thought. So in terms of the guidelines and stratifying the patients who should be eligible for in-person versus virtual, it also depends upon the risk level of the patient. If they are chronically ill, post a certain age, so there can be some thinking that can be done to develop an algorithm to identify, okay, these are the patients who are higher risk. Maybe we should not bring them in if needed, versus here's somebody who is 25-30 years old, and if they need to come in for a annual wellness visit. So it's a factor of how chronically ill you are, what are your comorbidities, what's your age, what are some of your other risk factors based on demographics or social determinants of health, the zip code that you live in. So there can be a combination of all of those factors, and we can help develop an algorithm to identify, okay, this is the patient, you should maybe bring them in, or you should maybe do that virtually. So those are some thoughts around how we can use analytic tools to help support that as well. So I know we were a couple of minutes over. Again, I wanted to thank everyone for joining. This has been very informative, and this has been a great discussion. So hopefully you took away some knowledge and next steps on how to engage with patients during the pandemic and beyond. And again, if there are any questions, feel free to reach out to us. We're happy to show you a little bit more of what we've done around this and our thinking around some of the things we've spoken about on this workshop. So again, a big thank you to everyone, and hope you have a great weekend ahead.
Stay safe, everybody.
Thanks, guys.
Thank you all very much.